Is Joost Wiersinga, and I work as an infectious disease consultant in Amsterdam UMC. Within the Survive Sepsis Campaign Guideline Committee, I represent the European Society of Clinical Microbiology and Infectious Diseases, ASCMID, and I had the privilege to serve as group head of the infection section of the Survive Sepsis Campaign Guideline Update of 2021. On behalf of my fellow panel members, I would like to give a short overview of some of the new recommendations in the infection section. I can only highlight a few, but with an emphasis on what's new. The infection section covers four major areas: diagnosis of sepsis, timing of antimicrobials, when to start, de-escalate, and the duration, antimicrobial coverage, and source control. Let's start with what's new with regard to the diagnosis of sepsis. As we know, the signs and symptoms of sepsis are non-specific and often mimic multiple other diseases. Since there's no gold standard test to diagnose sepsis, one will often have a differential diagnosis apart from sepsis alone in a patient with organ dysfunction. Indeed, 1/3 of or more even of patients initially diagnosed with sepsis turn out to have a non-infectious condition. We now do stress this point and recommend for adults with suspected sepsis or septic shock but unconfirmed infection to continuously re-evaluate and search for an alternative diagnosis and to discontinue empiric antimicrobial therapy if an alternative cause of illness is demonstrated or strongly suspected. Then the subject of timing of antimicrobials. The optimal timing of antibiotics in sepsis remains a hot and happening topic with over 5,000 articles published in PubMed to date. But the bottom line seems to be the following. For adults with possible septic shock or high likelihood for sepsis, we recommend to administer antimicrobials immediately, preferably within 1 hour of recognition. The data is less clear for adults with possible sepsis without shock. In these cases, we recommend the rapid assessment of the likelihood of infectious versus non-infectious causes of illness. This rapid assessment includes history and clinical examination and tests for both infectious and non-infectious cause of acute illness and immediately treatment for acute conditions that can mimic sepsis. Of course, if concern for infection persists, the antimicrobial should be given within 3 hours from the time when sepsis was first recognized. And do also please refer to the new figure 1, which provides guidance on the timing of antibiotics in sepsis. So what about the duration of antibiotic therapy? We now suggest for adults with an initial diagnosis of sepsis or septic shock and adequate source control, where optimal duration of therapy is unclear, that one can use procalcitonin together with clinical evaluation to decide when to discontinue antimicrobials. But how often is the optimal duration of therapy really unclear? I would like to refer also to the new table 4, which provides an overview of studies on the optimal duration of therapy in pneumonia, bacteremia, intra-abdominal infection, and UTIs. In general, shorter duration of antimicrobial therapy are recommended. And of course, do not forget antibiotic stewardship principles. We would like to stress the importance of daily assessment for the de-escalation of antimicrobials. And the third part, what about antimicrobial coverage? What to give? For adults with sepsis or septic shock and high risk for multi-drug resistant organisms, it is preferable to use 2 antimicrobials with gram-negative cover for empiric treatment over 1 gram-negative agent. For adults with sepsis or septic shock and a low risk for multi-drug resistant organisms, one can suggest against using 2 gram-negative agents for the empiric treatment as compared to 1 gram-negative agent. And for adults with sepsis or septic shock, double gram-negative coverage, once the causative pathogen and susceptibilities are known, is not indicated. Importantly, with regard to the delivery of antibiotics, for For adults with sepsis or septic shock, we suggest using prolonged infusion of beta-lactams for maintenance after the initial bolus over conventional bolus infusion. Lastly, the fourth point with regard to source control, we recommend for adults with sepsis or septic shock to rapidly identify or exclude a specific anatomical diagnosis of infection that requires emergent source control, and to implement any required source control intervention as soon as medically and logistically practical. The full guidelines are available online in the journals Critical Care Medicine and Intensive Care Medicine, and further education material can be found at survivingsepsis.org. I do realize that this was just a quick snapshot of the given recommendations in the infection field, and I sincerely hope that these guidelines will find their way and are helpful in your daily practice. Thank you very much.